All right, we will do just a quick run around the room so you know who we are because this is your first time sitting in committee. So I'm Teresa Wood from Waterbury. I also serve Bolton, Buell Score, and Huntington. And we'll go to the left.
I am Ray Garofano. I live in Essex and also serve Essex Junction.
Hi, Jubilee Miguel. I represent Bridport, Middlebury, Geneva, and Cambridge. Hey, Esme Cole. I represent Hartford.
I'm Zon Eastus. I represent Guilford and Vernon State.
And Todd sits there. Okay.
Go ahead, Todd, if you want to introduce yourself.
Yeah, hi, I'm Todd Nielsen. I represent Brandon and Forestdale.
Brenda Steady, Milton, East Milton, Westbrook.
Doug Bishop, Colchester, Chittenden Times.
Hi, Eric McGuire, Rutland City.
Hi, Dan Noyes, Woolgate, Hyde Park, Belvedere, and Johnson.
And Donahue, Northfield, and Berlin.
And then we go around the outside too.
Oh, my name's Zoe. I'm an intern for Zelton.
Okay, great. And our wonderful
Lori Morse, committee
assistant. All right, and now introduce yourselves for the record and happy to have you. Thank you, Barry, for being here.
For the record, Amy Johnson, Vermont Care Partners Director of Government Affairs.
For the record, Delana Norton, Executive Director of Champlain Community Services. And thank you for having us today.
And I'm Gloria Quinn. I'm the Executive Director of Upper Valley Services. So we're going to spend a lot of time talking about intellectual and developmental disability services. I'm going to do a quick run through and I'm going to do it in like 2 or 3 minutes because I want you to hear from folks that run the agencies versus me. I'm here every day. So if you want to find me and talk to me, I'd love to talk to you. So really quick, just kind of high level. I know there's a lot of new people on the committee. So Vermont Care Partners, we're supporting designated and specialized service agencies in our network. We have 16, there's 18 altogether in state statute. 16 of them are part of Vermont Care Partners. And so this just shows you where our agencies are and what we provide. So there's specialized service agencies. You'll see the type of agency and the services that we deliver. So some folks deliver developmental services, some mental health, some are substance use providers. You might hear preferred provider get around the state house. That's what that means. Some people do all 3, some people just do 1 or 2, but this gives you kind of a rundown of in your area, what does your DA or SSA do? So what is a DA or SSA? We're created in state statute. People often ask what's the difference between a DA and SSA. So really just broad strokes. Designated agencies have a specific catchment area that they support. The other thing is our services are voluntary. That's really important. Designated agencies have a no reject policy, whereas specialized service agencies, that isn't the case. Specialized service agencies have an open catchment area, more than 1 geographic area. So I think that's important to note. We're grounded in the philosophy of home and community-based care. That's a big part of what we do. We do run the gamut of prevention all the way to crisis services and kind of post-crisis intervention. And I'll show you a quick slide on that. But we're really, meeting people where they're at, the right level of care, the kind of the right place, the right time, what people need. So very person-centered, most supportive, least restrictive. That's what I was looking for. It's somewhere rattling in my brain. So again, all of our agencies have some configuration of these supports. Again, this is high level. Some of our agencies have multiple hundreds of people. In total, we have 6,000 people that support the DAs and SSAs. So we do a lot. We have children's mental health, adult mental health, emergency services, our crisis-based continuum. Our IDD supports intellectual and developmental disabilities. We'll get into that a lot because we know this committee focuses on this work. We also provide substance use supports. We're part of the preferred provider network. Not everybody is part of that. There's a lot of other people that touch substance use. So we're not the only ones, but a lot of what we do is kind of that one-on-one clinical care. And then community outreach and education. I want to mention that we also support our aging population. You will hear 2 specific programs that we do support IDD folks and also older Vermonters. So one of the programs we talk about in this committee is our elder care program. That's for individuals who are aging at home who have co-occurring disorders, so substance and mental health barriers, but that they want to age at home and be supported at home. It's a great program. In 24 years, it hasn't had an increase, so there's some challenges with it. And a little later, you'll hear more about our adult family care program. So 3 key areas of our work: upstream supports. So we're talking about social drivers. So case managers are out helping people to meet their basic needs. We're intervening early. So that's identifying issues, getting in early, and supporting people so that they don't have to hit higher levels of care. That's really important because it's supportive of the individuals that we serve, and it also that crisis continuum is really great, but it also is much more expensive than our prevention services. And then we have our holistic interventions and then our crisis continuum. We'll talk a bit about crisis in a little bit, but I want to note the thing that I find the most important as somebody who worked for the DAs for 9 years. Everybody thinks that the DAs and SSAs, it's in an office, one-on-one, some kind of therapeutic intervention, where most of our services happen at home, community, schools. So you can see there the breakdown: 64% happen in community, whereas 36% happen on site. I have an impact report. I'll send it to you. You can find out all kinds of great data. I'm not going to go over this, but we provide a lot of services. We support a lot of people, and we do really great work. So impact report will be sent to you.
Can I just ask
Yeah.
a quick question? And it might not be a quick answer, so you might not have it today, but it would be helpful to know the answer to this question.
Sure.
Of the services authorized and funded, what percentage of those are actually provided?
I don't have that percentage for you, but I'll get it for you.
Okay, and I realize there's going to be a range depending upon agency and depending upon service, but and as you know, I know you've probably been listening, but we are going to be taking up H13, and it's going to be relevant to that. So and you'll all be back to testify about that specific bill. So just a forewarning, that information we'll be looking for that information then.
Prepare.
Yeah,
Yep. We'll get that for you. Thank you.
okay, thank you.
And so if we do a lot of surveying, we want to talk about how much we're doing, how well we're doing, and is anyone better off? So annually, we do client satisfaction surveys. This is just highlighting that people do like the work that we do and feel supported and are better off. And now I'm going to hand it over to the people that you really want to hear from.
So I'm going to start us off. I'm Gloria Quinn again, and Upper Valley Services is the designated agency serving Orange County and supporting people with IDD. We are the only county that has a sister agency that provides the mental health substance use. So we are really designated for IDD, serving folks with IDD, and also we serve people, primarily elders, who are in the AFC, the Adult Family Care Program. So the mission of all of our agencies in serving people with developmental disabilities is really person-centered approach. You've already addressed that, and very individualized approach, supporting people in their communities to be contributing members in the way that they want, supporting people to be as independent as possible, having the greatest level of autonomy as possible, and to live more and more these days safely in the way that they want in their communities throughout the lifespan. That's the piece.
So as Gloria mentioned, so again, I'm Delana Norton. I'm the executive director at Champlain Community Services, which is one of our specialized service agencies, or SSAs. Something important to understand about the designated agencies and specialized service agencies across the state is that the specialized service agencies oftentimes have just what it says, a specialty. And our area of focus at Champlain Community Services is our employment programs and our employment supports for individuals with intellectual and developmental disabilities. We'll oftentimes refer to things as IDD. IDD is intellectual and developmental disabilities, also including individuals with autism, just to give some context there. As Amy mentioned, and as Gloria noted, being a designated agency, the largest difference is that our designated agencies are geographically located And anyone who is found clinically and financially eligible for developmental services. So in particular, the designated agencies must deliver those services, where a specialized service agency can say, we don't have the resources for this, or we don't have the expertise for this level of care. And so tend to be more focused in on some type of specialized support. So here we are primarily going to be focusing on developmental services. And so across our system of care, there are various different types of programs that do not provide the same level of care. So one thing that is also important to understand about our system is when somebody's coming through the front door, we are exhausting every other resource. We are always looking at no more, no less. So here are various types of programs that provide different levels of support to individuals and families based on both that clinical and financial eligibility for developmental services. The program that we're going to talk briefly about today that is not a developmental services program, it is a Choices for Care program that many of our designated agencies and specialized service agencies also hold under their umbrella, is the adult family care home. So adult family care home, similar to some of the services that we deliver in developmental services, provide a wrap of services primarily for older Vermonters who are not developmentally disabled or did not meet that clinical and financial eligibility for developmental services. So today we're going to focus primarily on the developmental services home and community-based Medicaid waiver program. So you see all these other programs that are listed here, but we're going to focus on the home and community-based Medicaid waiver. And we're also going to narrow in on some specific supports with the home and community-based Medicaid waiver. So this is a program that came to Vermont when we closed institutional care. So when Vermont made the decision that we were no longer going to provide institutional care for individuals with developmental disabilities, we moved to a waiver. That is a blend of both federal and state funds that provide a wrap of services that are based on the individual's needs. And just as mentioned, we exhaust every other type of support that individual can be receiving prior to considering the waiver. And the waiver is designed to meet all the other needs that no other programs are able to actually meet.
Elena, can I just ask you to speak to, and you might, if I haven't looked ahead, so if you do this, just tell me, eligibility, so that people understand that there's kind of a two-step process to eligibility, the clinical eligibility and determining whether or not somebody has an intellectual or developmental disability, and a Medicaid eligibility, which pays for everything.
Yes. So right. There's two parts. There's actually three in the state of Vermont that we actually go through for the entire process.
Yeah.
So the first is whether or not someone's clinically eligible, which is determined by a psychologist or a doctor that does an entire clinical assessment of someone to determine that they meet that diagnostic criteria of either having an intellectual disability or a developmental disability or autism. So once we have the clinical eligibility in place, and sometimes one doesn't have to happen before the other, but the other piece is that financial eligibility. So you must be Medicaid eligible. And so there's a whole process of being able to apply for Medicaid. And so that also varies for individuals around how they enter into that system. And I don't know if you want specifics on that, but
we actually had a little 101 on Medicaid and eligibility. You can refer back to one of the slides from this morning, but and then
the third piece is in the state of Vermont, you actually have to meet a funding priority. So there could be somebody who's clinically eligible, but not financially eligible. Someone who's financially eligible, but not clinically eligible. Well, they are not going to make it to the next door. If you're found both clinically and financially eligible, then you get to walk through the next door, which is to determine whether or not you meet a funding priority in the state of Vermont. the bar is high in Vermont when we look at funding, a funding priority. So in the state of Vermont, there's various funding priorities. I want to say there's 8 of them. The door that most people end up coming through is that there is a health and safety need that is not being met. And if these services are not in place, they are in jeopardy of potentially ending up in homelessness, a hospital setting, not having the care that they need. And so that health and safety need, that funding priority is the highest. For individuals who are under the age of 18, the bar is even higher. You have to meet institutional level care. So you either have to be in a hospital already and unable to potentially discharge to your own home. You may have to be discharged to nursing home level of care, or you're psychiatrically hospitalized and you are unable to return home without this wrap of services in place. So yes, a very high bar when it comes to getting through these various doors in order to be able to even be considered for the home and community-based Medicaid waiver for Vermont.
Thank you.
Gloria's going to share with us a little bit about the actual services.
So the service options, the no more, no less really is the backdrop to all of this. So some people will just have service coordination, which is like case management. And we'll talk about the conflict-free case management and how that systems change is coming into play here. But for right now, service coordination is about program coordination around the person, essentially. And residential services is primarily what we're going to get into a little bit later, and that encapsulates in-home support, so limited supports with someone living at home with their family, supervised living, so intermittent supports that's tailored just to what the person needs, and group living or fully staffed supports. And that includes shared living supports. The employment services is Vermont, just as a note, I've worked in 4 other states, and this is now 41 years, and I've been in this forever. But Vermont has always been well known nationally for many things, and supported employment is one of them. We're very high marks still, and that is one of the services that people have an option if they meet the system of care priorities. Community supports, individualized community supports, primarily helping people to be really engaged and actively a part of their communities. Respite care is relief for families and for shared living providers, primarily, so that they can continue to provide the care. And I'm sure you've been hearing a lot about the many families who are aging and need more help and need alternatives. Because they are running out of steam, basically. Clinical and behavioral support, it's access to medical, nursing, primarily mental health services, therapeutic supports, and intervention. We're going to talk a little bit about how mental health supports is lacking, very much so, for people with IDD, intellectual developmental disabilities within the system, and that also is affecting people significantly at this time. Crisis services we'll talk a lot about as well, because that's been needed more and more. It's on the rise, the need for the crisis services and what's happening to people and what we are predicting is going to be happening down the road that we'll need to plan for. And I want to somewhat just apologize. We're trying to gauge how quickly we need to get through things so that we can leave room for questions.
Yeah, don't watch that clock. I realize you're talking fast, and this is not going to be the only opportunity that people hear about. We'll hear all about this again during the budget, FY26 budget. So it's really kind of meant to provide sort of like that introduction, which you're doing perfectly. Thank you.
Thank you. So as Gloria mentioned, you could hear from that list of services that were just detailed out, it is wrapping the entire person, and not everyone who comes into these services receives each and every one of those. It really varies and is very individualized. What we wanted to focus on today really are the residential services that are offered and the crisis services, just recognizing that we're in a situation today where we all know that we're experiencing this housing crisis. We are also in a situation where we have many unhoused individuals in the state. And so thought it would be important for you to hear the types of services that we currently put in place through home supports. So here, the numbers here are,
Am I in the way here?
No, you're good.
oh, they are updated.
Not for the, not for the.
Okay.
Not here.
So not.
So
Okay.
as you can see, right now in the state of Vermont, the home and community-based Medicaid waiver actually serves just under 4,000 individuals. And out of those 4,000 individuals, our system throughout the state is supporting over 1,500 individuals with some level of home support. So a large number of individuals who we currently are providing these home supports for. The most common is the shared living provider model. I wanted to talk a little bit specifically about that model because there has been a lot of press over the past several years, recognizing that Vermont does need to continue to look at other models and expand. However, I do want to acknowledge that this model is not only one of probably the most cost-effective model in the state when it comes to providing any type of home supports for individuals who require this level of care. We as a system have had a lot of tremendous providers over the years. In many situations, this particular model has provided a stable residential support model for many Vermonters, acknowledging there are definitely situations where this model was not only not appropriate, but not successful because of our challenges. Two, is a state where we are all aging. Our providers have also aged. The economy in Vermont has shifted. The family systems have shifted. And so when this model was first designed at the closing of the Brandon Training School, it was really working for many individuals with developmental disabilities. And today that has shifted and there does need to continue to be more choice. But I just want to acknowledge that for many individuals, this has provided a very stable support model for them. A model that has grown significantly over the years is supervised living. We have more and more individuals who are exiting their homes, growing into adulthood, and really want to be living on their own or living with a roommate. And so we provide that support that they may need to continue to live independently in their apartments. I would say, I don't have the exact statistic, but it is remarkable in the past 10 years, as we have done a better job as a state around collaborating with our housing partners. Gloria has a tremendous project that has gotten off the ground here most recently with working closely with Downstreet. So our collaborations with housing authorities across the state has also allowed us to be able to provide affordable housing for individuals with disabilities. And then we are able as the provider agency to provide the home supports that that person may need to live independently. So a very, although it's not obviously serving the largest number of people in Vermont, it has grown tremendously over the years. Another model that is growing very quickly, and I would say that in general, this is because we don't have a lot of other options, is our staffed living model. Primarily at our designated agencies where there is not the ability to say no. We have many individuals who cannot be served in any type of a traditional model. They are going and oftentimes cannot live with other individuals. So this number of individuals who we are providing home supports for in Vermont, oftentimes there would be no other type of model that was in place. We have already exhausted everything. Many of these individuals have oftentimes been in and out of hospital settings, in and out of various different types of shared living models or unique types of wraps for their home supports. And we were not able to support them any other way. So this is a smaller number, but does continue to increase because of our acuity in the state of Vermont. And group living is something that we've always had in Vermont. We do not have very many models. At the closing of the Brandon Training School, there were several different homes that opened up. And over the years, that has become less and less because we moved further away from group living. And that is something that continues to be discussed in Vermont around whether or not it makes sense in some situations to have a group living model. So we have a handful of group homes that are staffed here in the state of Vermont. Oftentimes very difficult to get into because the individuals who are living in those homes are oftentimes in a permanent residential situation. So the only movement that you see is somebody who says, I no longer want this, which very, very, very rarely happens, or that individual passes or moves out of the state of Vermont. So our next slide just shows.
I have a question, I have a question here. Representative McGuire?
Can we go back to that last slide just momentarily? You'll help me. Are you associating group living with the therapeutic community model? Because the therapeutic community model is still one of the most effective safety, stability, and most importantly, fidelity in regards. Are you associating group living with the therapeutic community model? Or are you still utilizing the therapeutic community model as outlined and not bringing in a group living? They are two different
Correct.
elements.
They are. So when I'm referring to group living, I actually did include those. The way I use some of the data that the state collects from us as DAs and SSAs, and they don't actually separate that out. For us as provider agencies, we typically separate that out because of the licensing around it.
Okay.
And so it is in this particular slide, it is combined.
Okay. Thank you. I appreciate it.
Yeah, no problem.
Thank you, Madam Chair.
And really this slide is to just illustrate the cost effectiveness when we look at our particular models of support, when we think of an individual who may need home support. So this slide goes all, shows all the way up to somebody who is going to be in psychiatric hospitalization, Brattleboro retreat, traditional hospital level care, VCIN, our Vermont Crisis Intervention Network, staff living, ICFs. So it just shows the range and just understanding that Vermont really has worked hard when it comes to being good stewards of our funding when we look at models for individuals with developmental disabilities, and not at all dismissing that we need to continue to expand what the models look like.
The other thing that we, the department, Dale produces on an annual basis is there's an annual report that shows how Vermont stacks up to the rest of the country in some of these areas as well. We should be receiving sometime in the near future. It's late. I'm not exactly sure when they're going to be getting it to us, but that's helpful information if you want to see how Vermont stacks up with other places around the country. Also, as the witness just said, we utilize Medicaid funding to a much higher degree than lots of other states to provide these types of services.
Glad you brought that up, because one of the things that I wanted to comment on as we start looking at numbers and some of the consultants that we have coming in and are providing some of those comparisons, it is not apples to apples, is what I'm going to say. That Vermont has always been well known for community-based services for everybody who qualifies, everybody with intellectual and developmental disabilities who qualifies. That is not the case in many other states. Some of the highest acuity, the folks with the highest acuity needs are all served within the community here. And in other states, when they're looking at that, they're comparing community-based costs. They're not looking at people who are in institutional care forensic units, for instance. So it's not always apples to apples, and we try to bring that in and bear. When you look at the numbers, the cost might seem expensive for some of these folks who have the highest acuity here, but comparatively, it's much lower than where they might be in other states. So I'm asking that you keep that in mind as you start looking at these numbers.
So, yes, go ahead.
Question, as we're talking about Medicaid waiver, is this lumped in part of the
Global commitment.
1115 waiver that we talked about this morning?
It's all global commitment, which is the 1115 waiver, yes.
Thank you.
So one of the things that we've collected, it's very hard to collect, but we've been really interested in seeing what's happening around folks with disabilities around crisis. What's causing the crisis and what level of crisis are they in, and how do we respond and support people adequately? So one of the things that is not well understood even nationally is that the percentage of people with developmental disabilities that have co-occurring mental health issues is significantly high, and it's estimated much higher than 47%. But what we're looking at here is about 47%. It's much higher for the folks in the agency that I work with. It's really more around 60%. And other health conditions is at about 39%. With trauma and abuse, again, the estimates are much higher than what we are reporting here at 38%. And at this is just a 1 month shot that there were 203 individuals with developmental disabilities, or 7%, who were at risk really for homelessness. They were in temporary housing, temporary spaces, and needing long-term permanent models of support. I'm just going to say it has been I have never experienced anything like it in any state that I've been in, and probably nobody else has either. People who, because of aging shared living providers or aging families, or people who are at a level of acuity or in crisis, trying to put something together that where housing doesn't exist or staffing is, there's significant shortages, has been incredibly difficult. And I almost don't think that sometimes when we're talking to state leaders, that they really understand it. We almost make it look magical. And what we hear are the places where it's not working, but there is so much that has been working. And I don't even know how we pull it together sometimes. And I will say that people work around the clock within these agencies, and we all do everything. It's a lot of shared roles, and we all have to dig in because the problems right now are extreme. And our concern is that we design very carefully going forward what we're doing so that we meet people and we don't exacerbate issues that are already at play.
So I just wanted to mention, Gloria, I know you're going to list the different ranges of how we provide crisis supports, and we only have a couple minutes, but this system, you saw that wrap services, there is no other safety net. This is the safety net. So there isn't a hospital, there isn't a level of care that when we have an individual where supports were not working, or for one reason or another, they fell apart, or a provider ended up in the hospital who was providing that shared living care. It's the agency who has to figure out how we're going to support that individual. There's no other safety nets like all other systems typically have in place.
And I see the time, so I'm going to jump around a little bit.
Okay, thank you.
So we do what we can. There are lots of reasons, but one of the things that have high acuity, people losing their home and their supports, and doing that, having that done repeatedly, I'm sorry, not like skipping over myself, is very traumatizing. And trying to piece something together that's really stable for people is extremely difficult. And in terms of the crisis response, agencies put together what they can in terms of response after hours lines. There's a lot of pieces that have to happen well for people to keep them in place, to help them stay stable. UVS, Upper Valley Services, runs 3 statewide crisis through the BCIS Crisis Intervention Network. There's levels of support, training, consultation, and 3 crisis beds that are in place. We opened 2 additional because the need was so great. So we now run 5 crisis beds that we offer to the state agencies. What I want to say briefly in the little bit of time, and please interject, there are many statewide systems changes that are coming in and coming in fast. It's an aggressive timeline. We have conflict-free case management. That is a federal mandate. We understand it. We support that. What I will say is that at the same time, we have payment reform, a total new design. We're very concerned about the aggressive timeline, and the ultimate goal, what we care about, is that everyone that has stable housing and models of support in place, that people stay intact, their services stay intact. So as we come back down the road, it's going to be all about, we want to make sure people's lives are stable. There is no other safety net. There isn't available housing. There aren't more stable. So the shared living provider situation has in it both the staffing support or the support and the housing in place. So whoever is doing well in those situations should stay in those situations because there really isn't anything else. And it's exorbitantly expensive to put a staffed model in place for people who no longer are able to stay in place. So we're concerned about that. We're concerned about resources for people, stability. You can see all of it. I don't know that we need to say any more because I already know you need to leave.
Right. It's all good. I mean, I guess what I would say is that the good and bad thing is that all the things that you are looking at there that are challenges are things that we are consistently hearing and that I know that we will continue to hear throughout the session. And, we'll do our best to be able to address them within the resources that we have. But, thank you very much for being here. Thank you to, I'm going to say thank you to Amy for always being in the building because if we ever have any questions, she is she can't answer them. She's able to get us the answers and we appreciate it. And I am going to say that Developmental Disability Services are finally being represented by Vermont Care Partners in the building. So that's a good thing.
And we're happy to come back anytime.
Y'all will be getting invitations when we talk about the budget and for you, Representative Nielsen, who is not feeling well today, so that's why he's on Zoom, and Representative Noyes are the budget team for Dale. And so I'm sure that they'll be in touch once we hear the governor's budget. And we're going to start work next week on H13, which is the Medicaid rate bill. Which all is obviously very important to the work that you're doing. So thanks very much for being here. Appreciate it.
Thank you.
Okay, folks, we are off the floor. Let me just give you, on the floor in the minutes. Let me just give you a update on our agenda. So we're going to the floor. There is ethics, rules, and decorum training right after the floor. Okay. If that is the, what I've decided to do, because we are still working on the memo, I have asked permission to have a one-day extension. Let me just see if she texted back. That's good. And okay, that's good. So we have a one-day extension so we can submit ours on Friday. So I am, however, going to be asking that we have discrimination prevention training, which is a small group of us. And I have been asked to make sure that people pay attention and not be on their computers and cell phones for training and to be respectful of the, hey, Todd, and to be respectful of the trainers. Apparently, there's been some feeling among, I got you in a second. There's been some feedback from the trainers, let's just say. And Lori, I know that has been happening both on the House floor and across the way, and I'm not sure which place we're supposed to go.
I will see if I can.
Okay, thank you. Then it is Vermont Community Action Partnership Day, so we're going to be hearing from those folks. But in between there someplace, so please watch your texts, okay? Please watch your phones. We are going to be coming back to this room. It may be before floor tomorrow morning. I'll let you know that by the close of business today. Or or we may be able to figure it out after the community action partnership, but I hope to be able to have it.
Or after the four should be, and before discrimination.
Well, we're gonna be more than,
there.
yeah, we're gonna need more time than that, yeah.
That's tomorrow.
Yeah, so we have to get the memo done tomorrow. I am going to endeavor to send you out a draft by close of sometime business. Don't count me on 5 o'clock because it won't be 5 o'clock today.
Business goes late.
Business goes late, right. And so if you can review that before you come to, well, before we come to the discussion, and you will see a couple of different options in there, okay, for us to look at. Yes, go ahead, Todd.
Am I able to do this?
Yes. Oh, you mean for the training tomorrow?
I thought we were doing training tonight.
Yes, we have training. No, I don't know the answer to that, to be honest with you. Betsy Ann would probably know that.
Yeah, I don't know if that one is, but the other one's just because we're.
Oh, you want to know what? It is live streamed.
Yeah.
So you won't be able to zoom in, but you can go to the House YouTube channel,
I will.
the regular House of Representatives YouTube channel, and you can watch it there.
Perfect, thank you.
Okay.
Have a good
Hope
night.
you, all right. Hope you feel better.
Yes.
Okay, so do I.
Okay.